my name is Lydia Carlson, and I am going to be presenting my PDSA project on severe preeclampsia treatment and time frame. All right. So first of all, we're going to do some background information on what preeclampsia is. Preeclampsia is defined as hypertension in pregnancy that is greater than 140 over 90. It occurs after the 20th week of pregnancy with no previous history of high blood pressure. It can also be defined with a 24-hour urine test that is greater than 300 milligrams of protein. Edema used to be considered a part of this diagnostic criteria, but it is no longer used as a diagnostic criteria that needs to be met. We base it off of the urine protein as well as the elevated blood pressure. Severe preeclampsia is when a pregnant woman that is greater than 20 weeks pregnant has blood pressures that are greater than 160 systolically and 110 diastolically, with over 500 milligrams of protein in a 24-hour urine collection. Who gets preeclampsia? Lots of women are at risk for preeclampsia, and those that are at risk are those that are having their first baby or those that it's their first baby with a new partner. Genetics also play a role, as family or personal history of preeclampsia puts someone more at risk. The maternal age, if you're less than 20 or older than 35, you're at risk, and there's an increased placental size puts you at risk, meaning multiple gestation or that those with diabetes, and then those that are of the African American race. When does it happen? Preeclampsia occurs after the 20 weeks of pregnancy, and if high blood pressure occurs before the 20 weeks, it is considered chronic hypertension or gestational hypertension. How does preeclampsia affect the mom? So what happens in preeclampsia is, with any high blood pressure, really is the constriction of the blood vessels. The constricted vessels from the hypertension in a pregnant woman, lead to injury to the endothelial lining, which leads to the platelet aggregation, which leads to increased vessel narrowing, which leads to decreased end organ perfusion. In this case, the placenta is considered an end organ, and it is perfused less. What this means is that the baby is no longer getting blood flow that is optimal. This could lead to eclamptic seizures, placental abruption, where the placenta just detaches completely from the uterus, hemorrhaging, and acute renal failure. So how does preeclampsia affect the fetus? The restricted placental perfusion leads to decreased fetal perfusion as the vessels narrow. This makes the fetus unable to grow as the maternal blood flow has placed growth restrictions on the fetus. The fetus is at risk for preterm delivery, placental abruption, which would then, if it wasn't caught in time, lead to fetal death. The common signs and symptoms of mild and severe preeclampsia are severe headache, dizziness, blurred vision, altered level of consciousness, hyperreflexia, nausea, vomiting with epigastric pain, impaired liver function, and pulmonary edema. Generally, one of the most common signs and symptoms that you see in newborn surgery with those that are preeclamptic are the headache, the blurred vision, and the numbness continuing in their extremities. Almost all of them say that they have a headache. You can tell if they're going to start to abrupt if they start complaining of abdominal pain, severe abdominal pain, as well as the increased blood pressures. So the California Maternal Quality Care Collaborative, also known as CSUSM, was founded in 2006 to drive improvement in the maternal and fetal medical world and end preventable adverse outcomes to maternal and fetal care. They recognized that opportunity to do better in the care of maternal and fetal medicine and used and conducted evidence-based research to found recommendations. They have annual projects that they work on, recommendations for, and provide task forces for, and the preeclampsia recommendations came from one of their annual projects a couple of years ago. They have since provided a toolkit with several algorithms that can be utilized to provide the proper care to moms and fetuses. The toolkit provided is a recommendation for all women with blood pressure within the ranges of greater than 160 severe preeclampsia systolically and 110 diastolically for severe preeclampsia. The current, so what happens when you get a woman with this is you retreat with blood pressure. Generally, this is with a manual blood pressure, or the initial one is a manual one, and then you retreat it. And then you need to treat it within 60 minutes. And ideally you'll do it sooner than that, but you have 60 minutes to treat it. It is treated with magnesium sulfate, labetalol, and hyperolizine. So my plan during this project was to find out how well my unit is performing to the standard of care in treating the severe preeclampsia within the 1 hour time frame. If it is not being done within an hour, I wanted to see what the barriers to the treatment were. So in order to do, I knew that I needed to gather a report of the data. There happens to be a class that I attended on preeclamptic management. I did spend time in triage. I reviewed what the triage process was. That's the ER for pregnant women after 20 weeks. I requested preeclamptic patients. So those that came in with high blood pressures, I would, if I didn't have an assignment already, I would volunteer to take them, and then I was able to review their charts if I was caring for them and find out what happened and if they were treated in time, and if they weren't treated in time, what could have been done better, or the time frame in when doctors responded and all that stuff. And then I also spent time with our labor and delivery educator, talking to her about what the standards were. She was able to guide me in the right direction about gathering information for the CMQCC, and she was just a really great resource to spend time with and talk to. So this report was taken from the data center from CMQCC. The most current information for the hospital I work at, Clea Delta, is listed in the orange, and the California average rate is listed in the red. Since the time frame of February isn't over yet, the most current hospital information that I had was through November 2016. And as you can see, Clea Delta was consistently underperforming. Oh, I'm sorry, you can barely see it, but this is December 2015 through November 2016. The data shows that there are things that can be changed in the practice at Clea Delta to improve these timeframes, that did change, showing the increase from our 66.7% in the orange in the third column to our tremendous increase to 75% that were treated within the hour time frame from September to November 2016. I was talking with my educator and a charge nurse about what could have changed, and they think that we really started hitting into educating about preeclampsia and what to do during this time frame, and that is what could have related to the increase. So I did take a class. It was at Clea Delta Hospital. What we did was review the signs and symptoms. We know the signs and symptoms such as headache, dizziness, blurred vision, but there are others that have the signs that it's progressed to a more critical situation, such as the severe abdominal pain, which is a sign that they're abducting, and it becomes a critical situation where you not only have a maternal life, but you also have a fetal life that you need to take care of before the fetus is no longer alive. And then difficulty breathing indicates that it has progressed, the high blood pressure has progressed into pulmonary edema, which also becomes a critical situation because our fetuses are alive based on oxygen flow. So if oxygen in general is taken away from the mom and the fetus, then your fetus is compromised. We did review a case study that I'm going to go over right now, and then we did a simulation, like if the patient came in, what would we do, why, and we went over all that. So here's our case study that we went over. This is a case that I had a couple, probably at the beginning of this PDSA, when I knew that I wanted to do the high blood pressure. So we had a patient come in. She was a grand multip, meaning she had more than 5 pregnancies. She had 8 pregnancies and 7 living babies. She had no due date. We had no prenatal history on the patient. She was unable to sit still. She came in at 2:33 in the morning. I work night shift. And she had an initial blood pressure of 220/140. We didn't get her urine protein. It was not assessed at that time, which is part of the CMC standard to determine preeclampsia. So it was missed, her inability to sit still, the increased blood pressure, it just wasn't done. There was questionable drug use and history of meth use. In fact, a history of meth use within 45 minutes of coming in. Complaints of lower abdominal pain and no history of other OB problems. Her second blood pressure that was taken, which is part of the standard, was 229/121. And at 244, so 11 minutes later, a call was placed to the MD that was on call. There was lab work and a beta-well IV ordered. However, the patient within that 11 minutes still had no IV access yet, because the patient would not allow an IV to be inserted at this time with her inability to sit still. The MD ordered the patient to be taken to the ER because he felt that it wasn't a labor problem. He felt that it was a high blood pressure problem and a drug use problem, and that if the drug use was corrected, that the blood pressure would go down. So during this time, they were calling the ER, seeing if they could take the patient. Meanwhile, my lead RN gets hold of this case, and she calls the MD back and says that this fetus is measuring approximately 30-some weeks. The blood pressure needs to be treated regardless of the drug problem. So what had happened was, in the MD's sleep, he had just figured it was a drug use problem and kind of blew off the fact that we needed to treat the abdominal pain and that there was a potential abruption that was happening with the meth use and the high blood pressure. So an RRT was called on the patient. The MD for the rapid response team did not respond, so he was not present. The blood pressure increased to 232/126. The patient was transferred from triage to the labor and delivery floor, and there was 2 of us that assumed care. The first dose of labetalol IV was given at 3:16. That's almost 45 minutes later, still within the hour time frame, but it took 45 minutes to get an IV access on this lady. It was given every 10 minutes times 4 doses, and the blood pressure did get lowered to 150/110, still within the preeclampsia limits because her diastolic is above 110. Meanwhile, the fetal heart rate was not assessed at this time because of her inability to sit still. We couldn't put the straps on her. There was uterine irritability noted, and a possible abruption might have been taking place during this time. So mag sulfate was initiated after the 60 minutes, but that's okay because we had done IV labetalol. There was variable D cells that started to be noticed once we got her on the monitors. So then the doctor was called back again. He reviewed the strips, the contractions, the fetal heart rate, and he decides that with her epigastric pain, with the variables, with her uterine irritability, that she's starting to abrupt. So he called a C-section on the patient. We got her ready, took her back to the OR, and at that time he noticed that during the surgery, there ended up being a 50% abruption. She was transferred to the ICU in critical condition. She had to get transfused with blood, and then the blood gases on the newborn were drawn and came back with a pH of 6.8. So that baby was in a lot of trouble. So had the doctor not called me at the time, we might have been dealing with a fetal demise instead of an actual live baby. So what is the process in triage? Speaking of the triage, the patient comes in at the front desk. If it's night shift and it's past the time of 15 hours, they're checking at the ER. If they say that they're over 20 weeks, they're taken up to our floor and they're checking at the front desk. The front desk then calls our triage, and they're walked. The triage nurse goes out and physically gets the patient, and they're walked back to triage by the RN. During that time, as soon as they get into triage, they're also weighed, and then the urine sample is taken if the patient can void at that time. They're placed on the monitor, and the initial vital signs is done. They only have 6 minutes to get the patient on the monitor and take those initial vital signs before anything else is done. So then they assess their chief complaint. An assessment is completed. The MD is called to get orders, and then the orders are initiated by the triage RN. So ideally, if our blood pressures are high, the triage RN is the one who initiates the protocol to get the IV medicine in. So in direct patient care, generally I get a patient that needs to be started on MAG that has been treated with the IV labetalol already. I had a patient a couple weeks ago that was on MAG. who had had 1 dose of IV labetalol, but her blood pressures were still in the 170s, and they had been for over 3 hours. So when I got the patient, I was able to give her 2 doses of labetalol within the 10 minutes, spacing out with 10 minutes, and the blood pressures came down to the 130. During this time, when any patient is on MAG, you always have to care for the patient emotions because magnesium makes somebody feel like crap, and we overload them on magnesium to stop the uterus from contracting to make sure that the baby is safe. Drug use, we see a lot of times with patients that come in with high blood pressure, especially the meth use, like the case study before who had used it within 45 minutes of coming in. Generally, if the pressures are unable to decrease, there is an emergency. So what could have affected the results from the study that was done over the past year? Our documentation system is such that there isn't a specific spot to put manual blood pressures. You have to annotate it. So if somebody put it in a different spot and that wasn't ran in the report, it could show that it wasn't treated in time. We do a lot of post-charting, and maybe the time frame was a little off when we post-charted. And for example, in the case study above, like the doctor wasn't awake in the middle of the night to fully understand the situation. So that took time away of treating within the standard time frame. And then communication, always communication, clear communication with the doctor and with the nurse, and the nurse advocating for the patient, and knowing what needs to be done at the time that it is being done. So how can our time improve? We need to stick with the 6-minute triage time frame and get our patients assessed and on the monitor within 6 minutes to know if it's a blood pressure problem. We always need to communicate and be assertive for our patients. We need to make sure that prenatal care is being done. That's actually, we have really good providers who try and make sure that prenatal care is done, and if it's not and they come in late, they do everything that they can to get as much history as they can in the shortest amount of time. And then if they come into the hospital with no prenatal care, we drop panel try and figure out what is going on right away. And then to treat and recognize signs and symptoms before they become critical, the CNQCC has a whole toolkit about prevention of preeclampsia and like initial warning signs and what to do before then. And then education. There's just not enough education that can be done to our patients, to our staff, to everybody to be ready for this type of situation. So the action, our unit is undergoing significant change right now. The local hospital about 10 miles away recently shut down their labor and delivery department. So our hospital has become the only option for delivering babies within about a 30-mile radius. So our numbers have increased dramatically. Because of this increase in numbers, we see about 850 people in our triage every month, and we do about 350 deliveries. So several new staff members have been hired, most without labor and delivery experience. I was one of those nurses. I was hired about 7 months ago. So I'm still learning, and this is all new to me, and it's exciting, and I like these critical care patients in labor and delivery. So in order to assist those of us that are new in the proper procedure of the preeclamptic patients, I attempted to make these little miniature handouts that we put information on a badge for quick and easy access, but it was too small. So this was algorithm, but it just was too small to read. So I ended up getting permission from my nurse manager to put it in a chart display that we have in our hallway. So I now have a newfound knowledge about what to do and what the standard procedure is, and how to make sure that we get our patients taken care of. And then communication, I don't think that there's ever enough communication. Blood pressure is something that we always watch in labor and delivery, whether it be getting too low for an epidural or whether it be getting high and knowing how to do it right away. And then there's my references. Thanks for watching.